Hello everybody, I'm very pleased and honored to present to you today the PAOLA-1 trial. PAOLA-1 is the academic sponsored trial we're evaluating the maintenance with Olaparib in combination with bevacizumab in patients with newly advanced ovarian cancer receiving a standard of care chemotherapy plus bevacizumab. This is our disclosure. First-line bevacizumab increased response rates, prolonged progression-free survival, and also overall survival in some high-risk subgroup. And so it is a current standard of care for most patients with newly advanced ovarian cancer. The Olaparib, a PARP inhibitor, reports precedent PFS benefit as a first-line maintenance monotherapy in patients with BRCA mutation. And the activity of PARP inhibitor is observed beyond BRCA and was increased when combined with anti-angiogenic agent. And so in this context, this academic-sponsored trial is the first randomized trial to explore the efficacy and the safety of a maintenance in combination with Olaparib and bevacizumab in patients with newly advanced ovarian cancer. So the patients at the stage 3 and 4 were included in the clinical trial with an high-grade serous carcinoma and were in partial or complete response to a standard of care first-line treatment, including bevacizumab. 806 patients were randomized to receive the maintenance of Olaparib plus bevacizumab versus bevacizumab, who are an active control arm. Patients were treated for up to 2 years with Olaparib and up to 15 months in total with bevacizumab. There are some stratification factors as tumor BRCA mutation and first-line treatment outcome. The primary endpoint was the investigator assessment of the progression-free survival by RECIST, but we have other secondary endpoints as time to first subsequent treatment, PFS2, overall survival, and for sure, safety and quality of life. So the PAOLA-1 met its primary endpoint for a statistically significant improvement in progression-free survival in the ETT population in favor of the Olaparib arm. The median PFS increased from 16.6 months in the control arm up to 22.1 months in the Olaparib arm. And so what's that mean? For ovarian advanced cancer who receive chemotherapy plus bevacizumab plus Olaparib, in this trial, they benefit of a median time of 30 months, nearly 30 months, without relapse. The subgroup analysis are also really interesting to report. In the BRCA mutated patient, an hazard ratio of 0.31 in favor of the combination of Olaparib plus bevacizumab is what we observe in the SOLO-1 trial, where Olaparib was evaluated monotherapy compared to a placebo. And as we have more stage 4, more patients with residual disease in the PAOLA-1 trial, it is interesting to note that our PFS in the control arm is longer than in the SOLO-1 trial, which is probably due to the use of bevacizumab. Beyond BRCA, in the HRD population, we also observe an hazard ratio of 0.33, which is very similar to what we observe in the BRCA mutated population. And finally, a new population of patients was identified with an HRD test positive without BRCA mutation, where the hazard ratio of 0.33 report that this group of patients experienced a substantial benefit with the combination, with a median PFS improvement of almost 1 year. And so our conclusion for this clinical trial is to say that PAOLA-1 population is representative of the majority of patients with an ovarian cancer is first line, as the patient selection was not restricted to surgical outcome or BRCA mutation. This trial met its primary objective, demonstrating a significant improvement in progression-free survival for the combination of Olaparib plus bevacizumab compared to an active control arm. And the pre-specified subgroup analysis report that patients with tumor BRCA mutation and patients with an HRD test positive have the greatest benefit. And the result reveal a new population beyond BRCA, HRD positive, who experience a substantial benefit with the combination of Olaparib and bevacizumab. I did not detail the safety, but I can say you that the safety profile of Olaparib in this trial is similar that we observed in previous clinical trial where Olaparib was evaluated in monotherapy, and adding Olaparib did not impact on the bevacizumab toxicity and quality of life. Thank you very much.
Thank you, Isabel. Now it's time for Susanna Banerjee to comment on this study.
So thank you. So it's my role to try and put this into context. So just to remind ourselves that ovarian cancer is the 8th commonest cancer in the world, with 295,000 women being diagnosed and over 185 deaths. So the issue with ovarian cancer is that the majority of women relapse, and that's the real issue. So 70% within 3 years, and the 5-year survival for stage 3 is 20%, and for stage 4 disease, 5%. So PARP inhibitors have revolutionized the treatment landscape of ovarian cancer. PARP inhibitors, so Olaparib, which we've heard about, niraparib and rucaparib, are approved in recurrent ovarian cancer and have been shown to improve the progression-free survival. But if we're really going to have a chance to increase overall survival and hopefully more women cured, we need to bring these treatments into the first-line setting. And here in this presidential symposium last year at ESMO, and in this press release, you heard me talk about the results of the SOLO-1 trial. So the SOLO-1 trial has changed the landscape of first-line treatment. This was presented at ESMO's presidential session last year and published in the New England Journal of Medicine. And what that showed was that for women with BRCA mutations, following chemotherapy and having had a response, to then have maintenance Olaparib for a 2-year period. And what we saw there is that women, compared to placebo group, which was standard of care, that they had a hazard ratio of 0.3, which translated to a median progression-free survival of over 3 years compared to the placebo group of 13 months. So what does PAOLA-1 and Isabel Ray-Cockard study add? And what else are we going to hear during this Congress? Well, there are 3 studies in first-line setting presented in today's presidential session. You've already heard the results of PAOLA-1. There's also the PRIMA ENGOT-OV26 study and also the VELIA study. Now, the key questions for me as a clinician and a trialist is how can we improve on the results and the standard of care that we've had so far? So the main questions are, can more women benefit from a PARP inhibitor in the first-line setting beyond those women with BRCA mutations? And we've eloquently seen from Isabel Ray-Cockard that that is possible. So the next main question really is, if patients can benefit beyond patients with the BRCA mutation, how can we best select which patients are going to benefit for the longest time? That brings in the concept of HRD deficiency. The other question is about, can we improve by combining treatments? So, for example, you heard in PAOLA-1, Olaparib combined with bevacizumab. So taking those 2 main points, the PRIMA-1 study was looking at niraparib as maintenance treatment. So just like what I said in SOLO-1, no combination, maintenance treatment alone, but with the PARP inhibitor niraparib beyond women with BRCA mutations. And the key point there is just like what we've seen in PAOLA-1, is that we've got confirmation that more women can benefit from PARP inhibitors. So we also see that with the VELIA study, which is a US-led study, which is looking at combining a PARP inhibitor Olaparib with chemotherapy at the same time together, and then having maintenance Olaparib. And you'll hear the results later on today, but essentially that shows that chemotherapy with Olaparib and Olaparib maintenance therapy is better than no PARP inhibitor alone, and that's been shown in patients with and without BRCA mutations. So the real questions, I think, are, we know now, for the end of today, the presidential sessions, that we can use PARP inhibitors in the first-line setting beyond women with BRCA mutations. I think the key question really is, what about patients that don't have HRD deficiency? We do know the patients with BRCA mutations and that are HRD positive have the greatest benefit from either a PARP inhibitor alone or indeed in combination with bevacizumab. And I think that I'm very happy to take questions later on, but in the interest of time, we'll move on.